and Dr. Vimal Raj is our radiologist expert. So Mithun might join, Mithun might not join, and I'm not sure about him, but if he can join, it will be great. And as always, we aim to keep the discussion focused and clinically meaningful. So let us begin with the first case. Let me just start sharing my screen. One second. So Dr. Marine will be presenting from my side, and we will start with the case one, which is the most complicated. Yeah.
Uh, Good evening, everyone. This is a 55-year-old lady. She's admitted with us right now. She's a known case of dyslipidemia who presented to us with complaints of 2 months history of dry cough and worsening dyspnea, which worsened over the last 3 weeks, and dyspnea progressed from grade 2 MMRT to grade 4. So before getting admitted in Amrita, she was admitted elsewhere. So her fever started around early March for 1 week. It was there, which was associated with myalgia and productive cough. She received oral antibiotics from an outside hospital, but there was no clinical improvement and hence was admitted. On admission in the other hospital, she was found to be hypoxemic, saturation of 89%, shifted to ICU. She received supplemental oxygen and IV antibiotics. She gradually improved and she was shifted out from the ICU and subsequently discharged at a saturation of 96%. Post discharge, again, after a few days, she developed generalized fatigue, dyspnea, fever, and cough and desaturation. So, when she was readmitted, she required 5 liters oxygen support. She has a history of SLE in her family. Her daughter is diagnosed with SLE and is being treated for the same. So on admission, she required 5 liters of O2. Once we shifted her to the ICU, we started her on HFNC FiO2 of 50% with flow of 40 liters. Hemodynamically stable, bilateral basal crepitations were seen on auscultation. Were heard on auscultation. These are her lab reports. Hemoglobin was low, 11.8 even at admission, and 9.2 on 31. Her platelet counts were holding to 287, 235 now. OTPT was mildly deranged, 102 and 90.5, but by 31st March, it was closer to normal 53 and 41. Urea creat were within the normal range. Sodium was normal initially and then it started dropping. Potassium was okay. CRP was 1.42, then increased to 6.85 and is normal now. Her ferritin levels were 783, which showed an increasing trend, 972 and 1753 on 31st. LDH was high as well. CK was high as well, 239, 398. PTA INR were okay.
Yeah, so I will skip this slide. We'll go back to that later. This was one rare case in which what happened is by the time patient came to us, we sent the profile, ANA screening, ANA profile and myositis profile. And I remember that I took over patient from ER on Saturday, and Monday Marine came and told me that ma'am, her MDFI is strongly positive. I think it was Monday evening we got the report. This is a very rare phenomenon because most of the times we get MDFI report very, very late. So this came very fast, and I think from that day onwards we started her initiated. Till then we were not thinking, like, it was not very bad CT scan. I would request sir to Vimalraj sir to share this CT scan, and then maybe we can discuss further. So this MDFI report came, and that time there was an outside CT scan available which was showing something which was very suspicious of MDFI only.
Okay, thank you. This is the CT scan of the 56-year-old lady, and this scan is dated on 19th of March this year. So if we can see the mediastinal window to start off with, there are small volume lymph nodes, nothing major, no major pericardial effusion, and the pulmonary artery is also not grossly dilated. And small volume mediastinal and axillary lymph nodes. When we look at the lung parenchyma, you can see that the upper esophagus is slightly patulous, but the main pathology are these peripheral areas of ground-glassed lungs with associated intralobular septal thickening with some air bronchograms. You can see all of these are pretty much peripheral in distribution. And then there is this extensive consolidative changes in the left lower lobe that the patient has struggled to hold her breath. This is more of an expiratory scan. The intervening lungs in between look normal. There is no nodule. There is no mass lesion associated with this. So at this point in time, we are looking at something which is like an acute process, which is going in with some organizing pneumonia component with multifocal areas of consolidation, diffuse alveolar damage kind of a pattern that we are seeing across here. You can see very well demarcated areas, but extremely inflamed areas. We do have a follow-up images for her. Now, this is going 12 days later. This is from 31st of March. And at this time, we can see that she's got a right jugular line in place. There is pneumomediastinum, which is mildly extending into the lung pleural space, but no secondary complications. And the same areas of peripheral consolidation, extensive ground glass changes are seen with some of the atoll signs around there. And the left lower lobe has slightly improved aeration, but the involvement is pretty much the same. So overall, acute inflammatory process, organizing pneumonia pattern that we are looking at in this case. And slight change, slight improvement, I would say, compared to two scans.
Yeah, we also felt so. Other than pneumomediastinum, we also felt that there was slight improvement, but it was not a easy case. She's still in ICU, and what we are facing right now is, like the day she was diagnosed, the next day I think the next day we started only on 125 milligram of steroids, and later on I changed it to 500 milligram BD and then 1 gram OD. That's what happened. And the very next day we started tacrolimus, IV cyclophosphamide on the third day, and I believe IV immunoglobulin and pulse steroids were started simultaneously. That was the time when the patient was. So these are the ABGs. So what happened was, even though we started all those things, 19th March she came, 24th March we shifted her to ICU on the day when we started her on all those things. That time she was requiring 5 liter on nasal prongs. That's why I have written around 30% FiO2. But as you can see, we were getting only PaO2 of 51%. Over 3 days, this particular thing was finished. This was the time, 28 March, when she was not improving, and I wanted to do plasma exchange. But both rheumatologist Mithun and even nephrologist suggested that when you have given immunoglobulin in less than 1 week time, if you do plasma exchange, it will be not good because it will wash out IV IgG also. So you have to repeat it, and patient cannot afford to repeat it. So I could not do plasma exchange for the patient. Instead, we added tofacitinib. I think it was added on the 1st of April on Monday. I think I added it on this Monday. On 28th of March, she is not intubated yet. She was awake proning, just like we used to do in COVID time. Initially, she improved from PaO2 of 50% to 81%, but today evening also when I saw, it is not 60, around 61 of PaO2 I am achieving. That is around 150, 100 to 150 ratio of PF. She is still in severe ARDS. She is still breathless when she is talking. And now I believe proning is also not working. She's going into metabolic acidosis, maybe because of sedation, which I am giving her Dexmed. And I don't know how much I will able to hold on for her. This is the ABG trend which we saw over a period of time. So started with 50 and now I am split to around 50, like 70 to 80. But for last 2 days, it has not reached even 70% of PaO2. And I'm really worried about these are the medicines which I have already utilized tacrolimus, immunoglobulins, steroids, cyclophosphamide pulse, and she's on currently tech and tofacitinib. Now the only thing which is remaining is plasma exchange. So my question is there any improvement in CT scan? What more can be done? Proning worked, but it's not simple ARDS. So I don't know how far it will work. And plasma exchange, if yes, when will be the right time? Should I start immediately? Or should I wait? Because I spoke to other rheumatologists also. They told 1 week window will be fine. By the time you have given the last dose of immunoglobulin, you can wait for 1 week. I don't exactly know. That's why. Yes, sir, Rajan sir.
Yeah, so basically, there are two things here, Asmita. I would first of all definitely hang in there because it it has been shown, and I've discussed this with people, that you just have to wait sometimes and be patient and don't do things that can create more problems, in the sense treatments you have given IV immunoglobulins, you've given TAC, and you've given cyclophosphamide.
And
And
tofacitinib. Yeah.
yeah, so I know Teja Kulkarni, who had come for our DLD meeting once, is doing a trial, and Athol may know the status of that trial. It's called the Strive IPF trial, where they're doing plasma exchange first, because you raised that concern of whether to give plasma
Yeah, it should
exchange.
have been
So
done. Yeah, first.
so the order is a bit reversed in that
Yeah.
trial. Therapeutic plasma exchange rapidly reduces the antibodies, rituximab deplete the B cells, and then IVIG acts in multiple mechanisms, half of which I don't understand. So you've given two of those. Whether exchange makes sense now, I'm not sure. I'd love to hear from Prahlad and Athol on that. But I would just wait. And, I know costs would be escalating. These patients land up going on ECMO, but, she's 55, right?
Yes, sir.
Yeah, so she's not old. That's it from me.
Yes, sir.
Prahlad, Athol?
Well, in silence otherwise, I agree with everything you've said, Sujit. And it's interesting, the MDA5 group have a reputation of always doing badly, and that's not so. If they're carried through the acute episode, at least in our experience, and our gathering data on this, they actually go on to do quite well in the long term. And I will mirror what you said because I worked with ECMO for some time. I was the hospital respiratory lead for it when it first came in, and we had several of these patients, and it took an awful long time to carry them through. And then if they were carried through, then they did well in the long term. Now, I think your management verges on ideal, and I only say verges because we don't know what ideal management actually is in this setting. But I believe strongly in the philosophy you've instituted, which is the crime is to miss an opportunity. So if you go through what you did, I think you've put together the right level of intervention. Whether, for example, TAC and a JAK inhibitor will work better in combination, we don't know. We know there's a trial which actually shows there's not much to choose between them given separately. I think you were correct not to give both rituximab and cyclophosphamide because you would probably have wound up with life-threatening infection. There's experience in a difficult GPA with the combination. People actually do worse if you use both together. And rituximab was going to take a while to act anyway. So I think your non-use of rituximab was correct, and I also would have chosen cyclophosphamide under the circumstances because this was moving so fast. So I can't improve on your management. I don't think we really know whether plasma exchange adds value in this situation. We know it does in other settings, but I do agree that if you were going to use it, perhaps the time was to use it early. But I don't know that it is actually correct mixed in with the other interventions you've used. So I'm
Yes.
only encouraging you, Sujit, that you hang tough at this stage, I believe.
I think I agree with you, sir. Now we have to be more watchful about the infections. She's now
Yes.
going to get surveillance cultures you should send, be to the markers for early, because we will not be able to understand infection which is happening or not with this sort of a immunosuppressants. So look for infections, beta-glucan, galactamin, and blood cultures, surveillance culture, what we say, and you may pick up some bad bug. Then you have to treat that, and it takes, I don't know how much time it really takes all this to work, but generally it takes a long time. Immediately this works doesn't work. And what Sujit says is right. I think sometimes we have to be a little slower rather than very aggressive.
So the timeline which I was thinking was this Friday, मतलब today. So we did ferritin yesterday. So ferritin when she came was 500. Then it went to 1700 on this Monday when I initiated her on tofacitinib. And Thursday evening, मतलब Thursday morning, we did ferritin, which came to from 1700 to 1500. And actually LDH and CK to came to below normal category. So I was thinking that ferritin might take little bit more time to resolve. I was worried about oxygenation part rather than inflammatory markers also, because
Yes.
I'm not going to hold, like proning is also not working anymore. So that is what my worry was, that and pneumomedia cinema already has set in. So what more can we? And I'm not
Yeah.
like with
NI,
the
and NIV we should avoid because she would
NIV,
likely to
yeah.
develop a pneumothorax.
Hi,
And
Asif,
I
I'm
don't.
here. I'm just wondering actually, what is the trough level of tacrolimus you are maintaining at the moment?
I didn't check it. I'll check it.
Yeah, is there any evidence, Prof. Athol, that we have to maintain certain level of trough in MDF5 when you are getting tacrolimus? Because in post-transplant patient, we're using certain level of kind of trough levels to kind of achieve the
I can check on that, no problem. So I heard from my rheumatologist friends, colleagues in Kochi that tofacitinib works very well. JAK inhibitor has come up like anything, and you please add it, and that was the reason I added. I'm not sure about the combination, but tofacitinib was recommended, and in our hospital also, whatever patient we started on tofacitinib did well. So that was the reason that I added. Cyclophosphamide, Professor Athol Wells told, we have also had the same, that rituximab doesn't work fast, and that is why cyclo was added. And we don't have any plan of starting ritux, but I might consider plasma exchange. I don't know, because most of the people have controversial results, doesn't work, no more role. Even rheumatologist does not believe in plasma exchange that much. So that is why I put it. So yeah, we will hang on. That's what I feel. Nothing more can be done. Yep.
Thank you.
Yeah. So let us move on to the next case. Case number 2. Yeah.
This is a 69-year-old lady from Kerala. She's a retired college professor who's a known case of rheumatoid arthritis and has been taking HCQ for the same, which was discontinued after 3 to 4 months. She is now presented with cough with white mucoid expectoration for the last 15 years, which worsened over the last 2 months, associated with dyspnea on exertion, MMRC grade 2. She has history of exposure to chalk powder for more than 34 years. Her vitals were stable and respiratory auscultation revealed bilateral basal crepitations. Her hemoglobin was low, 11.6, RA factor was positive, anti-CCP negative, ESR was high, 60, KL6 682, borderline high. There was no restrictive change on PFT and no desaturation was seen on walk test.
So there are two. She's following up in some other hospital. Even my hospital, she presented to me only in March, but we have almost 6 months, more than 6 months apart, two PFTs, which is not showing progression as such. And other than her symptoms, we don't have any problem here. So over to you, Vimal Raj sir. Yeah.
So interestingly, for this patient, we have three HRCT scans. We are starting from 2022. So this is from May 2022. Mild atherosclerotic changes, small volume mediastinal lymph nodes. There's a little bit of a thymic hyperplasia at that time, and everything looks reasonably okay in the mediastinum otherwise. When we look at the lung parenchyma, at that point, we are seeing very early changes of reticular opacities in the subpleural aspect of the lungs, starts from the upper zones. And as we go lower down, you can see more and more subpleural reticulation, very minimal traction dilatation of bronchi. As we come down, we are seeing more of these changes, which are more ground glass, traction dilatation of bronchi. No honeycombing is seen. So this was in 2022. Then if we look at 2024, very similar change. Looks a little bit more prominent, where we can see same subpleural reticulation, traction dilatation of bronchi, no honeycombing. There are focal areas of endobronchial mucus plugging that we can see in the lingula. And as we go all the way up again, slightly worsen. Then most recent scan, this is from 2026 March. What we are seeing is again subpleural changes, slightly, definitely worsened compared to before, but lower down, almost the same pattern, ground glass, subpleural changes. So if I just show you comparison, the film on the right side here, this is 2022. The images on the left side here is 2026. And what you can see in 2026, they're of different thickness, so they may be slightly difficult to compare. But there are some patchy increased areas of ground glass and mild worsening of reticulation. So overall, this is fibrotic ILD. The pattern is that of UIP, rheumatoid. It fits in with an ILD-based UIP, rheumatoid-based UIP pattern with a little bit of an NSIP overlap. Mild progression over a 4-year period that we can see.
Yeah. 1 second. I'm just start sharing my screen. I believe she is not on any significant drug other than HCQ from even rheumatology side. So we also felt there was no disease progression over last 3 years. So do we need to treat this? Like I I agree that there might be radiological. So here when we don't have a PFT progression, but we feel there is a radiological progression, do we need to treat with antifibrotic or add-on therapy, sir? Yeah. Yes, sir.
I'm going to
Paul is
comment.
smiling, so over to him.
I'm going to comment on the scan. So I do understand there's a pattern of what we call probable UIP.
Yes, sir.
Now, in an idiopathic setting with a former smoker, male aged over 65 to 70, about 80% of the time, you do a biopsy and there's UIP. But that's because in that setting, UIP is hugely more common than NSIP. So this pattern is highly nonspecific. If you start with a pre-CT likelihood that IPF is very likely, then probable UIP will usually be UIP. In rheumatoid, on meta-analyses, if you combine the two patterns, 4/7 of the time it's UIP, 3/7 of the time it's NSIP. So NSIP is hugely relatively more frequent in a setting of rheumatoid, and in other CTDs where UIP is less frequent, probable UIP is probably not UIP. So I would say here that we've got a pattern of NSIP in its behavior. And I think some of the glassy ground glass fits nicely with an NSIP. I think the very slow progression on no treatment fits nicely with an NSIP. And at this stage, I would manage for NSIP, and you may turn out to be right. I may be miscalling this. I may be being fooled. So you watch for progression, managing NSIP, and I think if you have progression in spite of management, you then throw your hands up and you add an antifibrotic drug.
Okay.
But the antifibrotic drugs have enough side effects with them that I think, given the slow progression to this point, I would go for civilized immunomodulation in the first place.
That
Maybe
is
mycophenolate. You've got to talk to a rheumatologist because mycophenolate's not going to do great things for the joints. So it's one of those situations where you negotiate with a rheumatologist.
okay.
But if the rheumatoid is reasonably mild and you're saying it's the lungs that should call the shots, I'd go to mycophenolate, and I would stay away from steroids.
Okay. Yes, sir. Rajan sir.
So, Athol, just a question to you. I agree with everything you said. Middle of the year, you'll have nerandomilast in the UK. Would you have offered that to her if it was available to you?
Well, firstly, you can only get it if there's progression in spite of management. And I wouldn't call hydroxychloroquine management, by the way. Not seriously for the lung disease.
She is on HCQ, hai na, Merit? She is on HCQ.
She's
Oh,
on
what?
HCQ, but she on
Stopped, ma'am.
CT, Vimal did say there's mild progression. That's the only reason I was wondering whether Athol had a low threshold for Narando when it comes.
No, look, if I could use it, I'm not sure I would use it just yet.
Yeah.
For me,
Sure.
that DLCO, you've got to say, is a bit worse than you think because her spirometry is up at 120, so she's high in the normal range. So 60 odd is 50% of her personal normal.
Right.
So I would say that you obviously are going to watch this closely, but the fact is it's not really moving. And I didn't know the trade name of what you said. Is she on mycophenolate already?
So this drug is just for cough, sir. We give it for
No,
cough. That's it.
that's just a cough suppressant.
Yeah, nothing.
Okay.
No medicines for any, not even arthritis, not even fibrosis. Currently, she is on symptomatic treatment.
Right. So I would say that playing the odds, she's more likely to have NSIP. I'm basing that on the CT picture in a setting where NSIP is much more likely than in an idiopathic setting, and also the disease behavior. This is not behaving like the UIP of rheumatoid. We know that the UIP of rheumatoid on average behaves like IPF. So the behavior is wrong. The scan is non-specific. And if you were managing idiopathic NSIP of this severity and you knew there was no change in the last year, I don't think I would use nerandomilast at this stage. I would say mycophenolate is a civilized drug. You don't have to go to the top dose of 1.5 grams twice a day.
Okay.
And you can be measured because these patients, once they stabilize with NSIP, often remain stable in the very long term.
Yeah.
So I would have said you can do it in 2 steps, and it's very reasonable to take just the first step at this stage because you're not being pushed into urgent management here by the behavior of the disease with time.
Yeah, I think that I will do. We'll move on to the third case. We have many pending cases, so I'm just finishing all those together. Yeah, over to you, Murray.
This is a 75-year-old male from Kerala. He is a known case of COPD, CAD status post CABG, diabetes, hypertension, dyslipidemia, hypothyroidism, and BPH. He complains of chest pain on and off for the past 2 years, which has worsened over the last 2 months. There's no positional or variation or any aggravating or relieving factors. He also complains of occasional cough. There's no significant exposure of family history. He has a history of right-sided pleural effusion, which was treated in an outside hospital in 2011. He underwent FOB BAL for the same, and the cultures and cytology, everything was negative at the time. He was admitted in February for AECOPD. His vitals were stable, respiratory auscultation was normal. His ANA by IF was 2 plus positive, CK was 446, KL6 was 1261. ANA profile was negative, and myositis profile was 2 plus positive for PL7.
CPK is also high. Yeah.
He showed restrictive change 56%, DLCO was 46%, 6-minute walk test, no significant desaturation.
Yeah, I believe we have given images. Yes, sir. Vimal Raj.
Okay, so we have two CTs for this patient, and this is the initial one from October 2025. What we are seeing in the mediastinal window is small volume mediastinal lymph nodes, some atherosclerotic changes, and coronary artery disease related changes. He's got some prior infarct and also coronary stents that we can see. When we look at his lung parenchyma, so this is from the October 2025, we can see he's got paraseptal emphysema related changes. There are some subtle reticular changes that we can see in the subpleural aspect of the lungs. And as we come down further, he struggled to hold his breath at that point in time. Again, patchy areas of reticulation, but more so what we are seeing are focal area. Let me try and show him this itself. So we are seeing some focal areas of fibrosis towards the subpleural aspect across here in the lingula. And as we come down into the lower lobes here, we can see that there is this dense area of consolidation with traction dilatation of bronchi, which doesn't seem to be symmetrical, seems to be very asymmetrical. Now, if I fast forward it to most recent scan, this is from March of this year, I'll just take to the top. And what we can see is again, paraseptal emphysematous changes. You're seeing more of subtle reticular changes towards the subpleural aspect of the lungs. And again, patchy areas of ground glass consolidation with traction dilatation of bronchi. And as we come further down, same area of consolidation. And these areas of band-like atelectasis that we can see where there is subpleural sparing in these areas with ground glass change. When we compare these between the two scans, there is, to be honest, the time span is about 5 months. There is very little or no change if we allow for the difference in technique that we are seeing. So this is a patient who's definitely got emphysema. He's got focal areas of fibrosis. The right lower lobe, I suspect, may be related to post-infected. There could have been some infection or even aspiration to account for this. But the changes which we are seeing in the other parts of the lungs are also suggestive of underlying interstitial process. Could be a viral post-infective change that is left behind or a non-specific pattern of ILD that we are seeing.
Is there any chance that I'm not sure whether this is the same case, but let me just see the questions because I am doubting.
Okay, no, it
No,
isn't.
na, yeah. So that's the problem. Like, one
Okay,
second.
let me just show you the case that you are showing.
Yeah.
Apologies, I think we did not synchronize well there.
So I think this patient will have some 2017 or 16 CT scan, sir,
Yeah.
which was in Amrita. And then there is outside CT scan, which was taken. And then both the CT scan, the reason patient was referred to us was the treating doctor suspected, is it cystic ILD or not? And then I went back and saw our old CT scan. That's what happened. Yeah.
Okay. One second. Okay. Atul, do you want to go ahead? You have your hand raised, I think.
Only because there was a long silence and I was going to sympathize with trying to interpret the CT because I think it is difficult. It's clearly not a cystic lung disease, but
Okay. Okay.
but I suspect strongly we may be dealing with two separate things at the same time.
Yeah. You were right.
Yeah.
So
So
you've
so
got
it's
an anti-synthetase antibody with an elevated CK, and you've got a smoker, and he may be aged. Did you say he was aged
74. Yeah.
But his lungs are aged 85 because he's got senescence pathways activated with smoking,
Okay.
which will tend to drive him towards an element of UIP. But if you go down to the lung bases, where I struggle.
I'll just,
Actually, yeah, sir,
Atul, I'll just
that
interrupt
was
you. I think I was showing a different patient, and what was presented was a different patient. So this is the patient which has been presented with, and I'll just show this.
I will swallow every comment I was about to make.
okay.
Sorry, apologies. So
That's right. I quite enjoyed commenting on that scan.
this is the scan from February for this gentleman. There is severe coronary artery disease with prior bypass. What we can see is pleural thickening in the right side with calcification. Both the visceral and parietal pleura are thickened with what looks like could be an early round atelectasis that we are seeing in here. And when we look at the lung parenchyma, there are areas of what looks like a simple isolated cyst in here, and then minor paraseptal emphysematous changes, few again isolated cysts. There are totally about 6 to 7 cysts in the lungs, which the lungs are otherwise clear. There is these areas of round atelectasis that we can see. Mild background of emphysema. Now, when we track back, we have a scan for him from 2011, so that's about 14 years ago. And at that point in time, we are seeing some of these cysts, so that cyst is still there. And again, at that time, there was a larger pleural effusion with some isolated cysts. So to answer your question, I don't think this is a cystic lung disease. I think there is definitely paraseptal emphysema with few isolated cysts. The right side is old infective pleural disease of some sort.
So when do we say cystic ILD? How many cysts are good enough to say it is cystic ILD, sir?
So anything isolated up to 5 to 7 cysts, we do not start to put in terms of cystic ILD.
Okay. And I don't have to treat this because over a period of time, even 2014 or 17 CT scan and this CT scan almost same number and same size of cyst, right, sir? Okay. I think that solves the problem. We don't have to any more workup just because we see one or two cysts. Do we need to jump and start investigating it like VGF level and all? I don't do all those things. So any comment on that? I have not done any investigation. I don't intend to do. But do you people recommend that we have to send? No need, na, sir, Rajan sir?
No,
I-
no, I wouldn't.
Yeah, I also want. I don't send for actually cystic ILD also sometimes it's very difficult to send. Yeah. Last.
This sort of case is difficult to classify, really. I mean, in some units, I think it would be viewed as a form of cystic lung disease, but I agree with the philosophy that if there are only 5 or 6, and you're in a position to say it hasn't changed for 10 years, then it's probably wise not to put a disease designation on the cysts. And we do have to remember that 20% of patients with cystic disease can't be classified. I can't turn this into pastel IP, for example, because any suspicion of autoimmunity is only very recent. So I agree with you. What troubles me slightly is the level of gas transfer, which I think from memory was 48, but it will be an overestimation, because if you've got the lung function there.
1 second.
I think the real value will be below 40, and I'll tell you why I think that. And you said he had trouble holding his breath more recently,
Yeah.
or recent CT. So
It's,
I'll tell you exactly why. It'll be quick, I promise, once you actually show the lung function.
yes, sir. Is it seen?
But I think it's an important point. The VA is 81%. The VA should be collinear with the FVC. The VA is the most difficult test to measure. There's huge variability. And when I see VAs measured several times in lung function units, they fluctuate wildly. And you calculate DLCO by multiplying VA by KCO. The real VA will be closer to 55. The DLCO will be down in the 30s. He's having trouble holding his breath when you do the scan. So I would have said that's the thing that slightly troubles me. I mean, I suppose you need to be sure he's not having pulmonary emboli, doesn't have a cardiac problem. You would have done all that. But it does trouble me slightly. That's all. That's the only thing I would say. So I think whatever else, if you're going to observe what's on the scan, it's going to be very close monitoring. Could the autoimmunity go with a vascular issue of some kind driving that DLCO? Maybe you should measure anticardiolipin antibodies. I don't know if you've done an echo. The KCO is not really at pH levels, but it's down, but that could just be the emphysema. And so when I look at that, it's not really an obstructive pattern, especially slightly. No, well, it isn't. It's slightly. But that's all. That's an awfully low KCO and DLCO for emphysema. And I'm not seeing much else on the scan.
Yeah, we don't have a rheumatologist, but if we remember what they say is you have to see the color and you have to see the positivity. So here we can see even color is positive as well as 2 plus. So maybe a rheumatologist consultation also will be worth asking for whether they want to do something. And his CK was also high, I believe. Yeah, CK was high.
I mean,
LFT,
I
yeah,
do agree with you that you don't want to rush into doing something here because you're not getting enough guidance from the scan.
yes, sir.
But I also think leaving it as an asterisk and further evaluation and close monitoring would be
Yes,
correct.
sir. Yeah, I will do that. Move on to the next case. Case 4. Yeah, this is the case which we saw the CT scan previously. Yeah, okay. Yeah, Merin.
He's a 76-year-old gentleman from Trivandrum. He works in the post office. He's a known case of coronary artery disease with moderate LV dysfunction, dyslipidemia, and hypothyroidism. He complains of dyspnea on exertion, MMRC grade 2, for the last 6 months. He had occasional exposure to pigeons, and he's a reformed smoker. He quit 20 years back. His vitals were stable, and there was bilateral basal crepitations on auscultation. His routine blood workup was normal. ANA by IF was 1 plus positive. KL6 was 590 negative. ESR was 6. ANA profile was borderline positive for nucleosomes. Myositis profile was negative. FVC was 55% when it was done in October, March. When we repeated at our facility, it was 65%. DLCO was 49%, KCO of 65, and VA of 75%. 6-minute walk test, he desaturated from 98 to 92%. 2DKO showed dilated LA, LV, mild pH, and EF of 40%.
Yeah, this is the CT which we saw previously, but sir can show again. You are muted, sir.
Yeah, I'll quickly summarize what I had shown previously. So there were atherosclerotic changes in the aorta and coronary arteries, and there is this paraseptal emphysema that we can see here. There is subpleural interstitial reticular changes as we come down all the way, patchy areas of ground glass within it. And then you can see some early areas of consolidation. And as we come towards the lung base, there is this focal area of traction bronchiectasis, fibrotic changes, and then all these reticular changes. Extreme lung bases, if you see on the left, is relatively spared, with some areas of ground glass reticulation on the other side. So what we are looking at, this is a combination of interstitial, combination of emphysema. The right lower lobe change that we are seeing is relatively different, so that could be a post-infective, but there is definitely an interstitial process that is going on in the background in this patient, which is non-specific at this stage.
So, my doubt for this patient was he has significant ejection fraction limitations with 40% EF and recent worsening of his symptoms. We did proning actually. I did prone CT scan just to rule out that is it related to congestive cardiac failure, but it is not, right? So that was the thing. And patient is quite asymptomatic, but he has auscultatory findings on both the sides. When I auscultated, surprisingly, I also felt that left side should have been clear, but I can feel crepitations on both the side equally distributed. So I don't know where I will put this patient, and he is not symptomatic for whatever we are seeing on his CT scan. So how to treat and how
So
to approach?
he definitely has ILD. I think that
Yes,
is
sir.
something which is
Okay.
definitely going on in there. That asymmetry could be a superadded infection, which is fibrosed in there, but I think there's definite background of ILD, and it doesn't look like congestive cardiac failure.
Okay, sir.
I enjoyed your presentation the second time as much as I enjoyed it the first time. We could just go to the lung bases, because I do wonder whether there are arcades perilobular change. And I think that when you talked about a band distant from the pleural, you can see places that there are arcades and perilobular change. And so I would be wondering, not certain, but suspicious, that there will be an OP stroke NSIP pattern bilaterally at the bases. Now, the moment you say that, then you don't know whether that exaggerated change at the right lower lobe is somehow part of the same process, or whether, as you say, there may have been separate infection, because, of course, it is asymmetric, but it's combined with a bilateral problem with crackles, which is probably OP and SIP. And maybe if you've got that problem, you're more likely to get an asymmetric problem with the second trigger coming along. So it may still be part of the same process. And if it is indeed OP NSIP, how old is the patient?
70, above 70, sir. I think 70.
76.
Yeah.
So, yeah, we would sometimes do a cryobiopsy in this setting, establish that it is OP NSIP and manage accordingly. Because your DLCO is down below 50%. And he may be on the verge of developing quite major NSIP. And I'm not sure the pigeon exposure is going to be relevant. Occasionally, of course, you get HP with an NSIP look, and it's not out of the question. But we would view this as idiopathic, I think, wouldn't we? And so my suspicion is that this is a form of NSIP with an OP element.
Do you really want me to do biopsy? I now remember that he
No,
was also referred for biopsy, but he has 40% ejection fraction.
No. You've got cardiac impairment. He's
Yeah.
76. I think that I would not myself do that. I think in Forley they probably would, but don't think I would personally.
I also want to, yeah. So we will treat as OPNSIP. I would rather treat because going through risk, they also don't want it. Patient is not very keen on biopsy. However, he will take treatment, whatever I suggest.
He's 76. What are you going to treat him with, Asmita? Because he's got exertional dyspnea. Could this be just a residue of his earlier smoking, Vimal? Smoking-related interstitial, like a CPFE pattern, or not likely, I thought?
Well,
No,
I think it's the OP element that bothers me. And I think I
Right.
would find it hard to fit that in with having smoked 20 years ago.
Sure,
And I agree with you. You'd stay away from steroids. You'd use a civilized mycophenolate dose.
sure,
You'd make sure that the cardiac problem is not somehow related, but he's not got antisynthetase antibodies, so I don't suppose he has a myositis
No,
cardiomyopathy.
he doesn't.
No, but be that as it may, I would treat, but mycophenolate's a reasonably gentle drug. And I think that there's more than just a smoking consequence.
But if it is a COP component, why not a small, like I'm so tempted to give 3 months of steroids because if that will get rid of his problem very fast and then MMF
You,
also simultaneously I can
you,
start.
you you could. I tend to abreact to steroids these days, but I think provided you're giving it only as a short, sharp burst, I think it could be seen as appropriate because
Yeah.
it helps to secure your sense
Yes.
if he improves. It's a management that in principle can be extended with mycophenolate in the long term.
Yeah.
So it's almost you're diagnosing by response to treatment the
Hmm.
importance of the interstitial element and the importance of ongoing treatment. So
Yeah.
there's not to be said for that. Some people would and some people wouldn't.
Yeah.
I think 3 months is too long, Asmita. I'd probably give shorter course of steroid and get
Yeah,
on my go.
Okay.
yeah, because you'll
That
get
also can be done. Two
you get.
months, sir. I'll give for 2 months.
I think it's
So
better
we can observe him for 3 months more before you put something. Because there is improvement in pulmonary function test.
No, but that's at two different labs, Prahlad. So I don't know if that's
Yeah.
improvement.
But
No, so that's the problem. I saw that, and he is symptomatic, and he's come to Asmita with the question of a biopsy, which,
Yeah. Yeah.
as
He was
Athol
referred.
said, probably Claudia would have biopsied that, but he wouldn't, and I
I
think
also would not.
immunosuppression then, yeah. But
Yeah.
76-year-old male get a bone density done before you give him steroids, and I would give
Okay.
less than 3 months for sure.
Sure,
I
sir.
would I would buy into a month of a reasonable
Yeah,
dose of
ठीक
steroid.
है,
yeah,
sir.
yeah, yeah.
Okay.
That's
Just
right.
Okay.
just a month, just a month.
Correct. Yeah.
Okay. 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 Agreed. Yeah, maybe. Moving on to case 5. Yeah.
Yeah. So this is a patient. I wanted a rheumatologist. I'm trying to get my rheumatologist on this call, but she is in Chennai with poor network. I have just 2 questions on this lady when we end. 82-year-old lady, married with 2 children and living in Mumbai. And she met me first in March 2018, cough with minimal sputum. She was treated with steroids by a pulmonologist in 2017 and felt better. Very vague joint pains. Her ESR was 135 then, rheumatoid factor negative, ANA 1 in 100. But based on her scan, which Vimal will show you, I made a working diagnosis of probably IPF then and prescribed her pirfenidone. I'm talking of 2018. And rehab, her diabetes was uncontrolled, and so I didn't want to give her steroids. Elderly lady. She sort of disappeared during the COVID years and came back after 4 years and is taking only 600 milligrams of pirfenidone now. She's complained of increased cough for the past 2 months, disturbing her sleep, and lies down most of the days now. For the last 1.5 years, she's lying down, feels tired most of the time. That's her examination findings, no family history of ILD, and then we got the autoimmune workup done because it had been a while, and that's what we saw. And I'll show you the blots later. The ESR has come down to 35, but we have a lot of, and I'll show you the blot that we ran. Can we get the next slide? With the
Yes, sir.
scans? Yeah. Yeah, maybe Vimal can show the scans and then I can show you the lung function.
I unfortunately only have the recent one. I don't have the older one
Okay.
in there.
So
So this,
Bhavin had reported very mild progression, but we'll see this one.
yeah, so this is from March of this year. Small volume mediastinal lymph nodes, pulmonary arteries are normal, mild coronary calcification, very small hiatus hernia. And when we look at the lung parenchyma, we are seeing these fine reticulations in the subpleural aspect of the lungs bilaterally, with some focal areas of cystic changes in the upper lobes. And as we come down, you can see they increase with areas of honeycombing, which have started to set in, with multiple layers of honeycombs in the lower lobes that we can see across here. Bilateral involvement. The fissures are relatively spared. On expiratory imaging, there was not much in terms of any air trapping. When we look at the coronal images, not very typical in terms of a straight edge sign that we can see, but there is definitely involvement of the upper lobes bilaterally anteriorly, and not classical for exuberant honeycombing, but it is getting towards that. So the pattern is that of UIP that we are seeing in here. And looking at Bhavin's report, Bhavin has said that there has been, as you said, significant progression of disease from 2018.
So he said a mild progression, Vimal. He didn't say a bad progression.
Okay.
Uh, and you know, the thing is she's just lying down and feels tired, very tired. And if I can see those lung functions, if you
Yes,
see
sir.
the lung functions done at the same laboratory, uh, you can, yeah. So this was a ANCA profiles negative, myositis negative. And then you had this ANA profile, which really confused me, which is why I wanted the rheumat on the call. But all these turned in positive. SSA row 52 ribosomal protein was almost 3 plus. Next slide. And then these are her lung functions. So she's not doing too badly in terms of lung function. Even now, today, even though she came in, she sat on a chair, but she was just looking tired. You know, DLCO 52%, predicted 6-minute walk, walking 212, not desaturating much. So my questions, next slide, Asmita, was, you know, we have an 82-year-old lady with a working diagnosis I had of IPF, has been stable on just 600 mg of pirfenidone. ANA serology is a little equivocal, a bit bizarre. Should I up that dose of pirfenidone now that she's on 600 only? Or should I immunomodulate in view of the serology CT findings that Vimal said were probably some features of CTD-ILD, you know, straight edge sign, and there's been reasonable long-term stability. But because of her age of 82, I was a little concerned about immunomodulation as well. So what would you all do? Prahlad at all?
I'll let Pravad answer first because I've answered first too often.
Prahlad.
I think in this case, I would like to keep a small dose of mycophenolate. It is very safe, I feel, even at 82 age. Okay,
Okay.
mycophenolate is very safe rather than putting and currently I would like to hold on antifibrotics. and just see whether after stopping, she's better, as well as her general condition is concerned, her appetite and other sense of well-being improves. Because sometimes these antifibrotics can cause at least more of weight loss, tiredness, fatigueness.
Okay, so she has herself reduced the dose by 60%, as you saw. So I was thinking whether to immunomodulate, but this tiredness, I couldn't explain that, and the fatigue, and what to do. And she's 82, yes.
Yeah.
That's all.
Yeah, I think it's slightly tricky. The scan is not tricky, is it? That's UIP, full stop.
Yeah.
No question. No question. But what you've got is, firstly, the FVC hasn't fallen. You're supposed to lose 1% per year due to aging. And when you factor that in, the FVC is identical
Yes.
to the first FVC. The
Yeah.
DRCO within measurement variation is unchanged. So you've got a combo, haven't you? You've got the serology, the fatigue, the elevated ESR, and the very slow progression. And you're starting with quite a good reserve. So there are two scenarios. Firstly, it is really IPF and you're getting some secondary autoimmune signal. With disruption to the epithelium, you do tend to start to see positive serology. People develop rheumatoid 3 or 4 years after a diagnosis of IPF. So it could be you're dealing with a secondary phenomenon, but the ESR was up from the outset. And I would think this may be an occult CTD-ILD. And because you've treated it early with pirfenidone, that's why you're seeing it's remained stable. And I would say on lung grounds, you've got no ground to change anything, but on quality of life with fatigue, maybe low-dose mycophenolate is worth a whirl, but it would have to be very low dose, wouldn't it? I mean, you would say that in somebody aged 82, a dose of mycophenolate of 250 to 500 twice a day is equivalent to giving somebody aged 70 a dose of a gram twice a day in terms of potency of side effects. So that's my only question. Do you or don't you add some mycophenolate?
Sure.
But I think you're doing it on quality of life grounds, aren't you? And you're hoping that the fatigue is part of a autoimmune disorder, and then you're hoping possibly slightly against the odds that the fatigue bit of autoimmunity might respond to mycophenolate. Now, in my experience, more often than not, it doesn't actually, but sometimes it does.
Sure.
Would I really add that for the lungs at this stage with an FVC that I would view as identical to the value of 7 years ago once you've knocked off 7% due to expected change from aging?
Sure.
I wouldn't be actually messing with where you are from a lung point of view.
Sure. Prahlad wanted to stop the antifibrotic. You wanted to continue it.
Well, I think she's got down to a dose that is acceptable to her. And if it is acceptable to her, I don't see any harm in keeping it going because you've had it in there from the outset.
Sure.
And with it in there from the outset, there hasn't been progression.
Right.
So my instinct is to leave alone in these sorts of situations. Now, if she tells you that she's finding this treatment troublesome, then that's different. But if she's saying, no, I can cope with it, it's fine, would you want to fix something that isn't broken?
Sure.
But her
Yes,
only complaint was fatigue, na, sir? She's feeling tired. So
She's
MMF
lying
will,
down.
yeah,
No, that's
MMF,
what Athol said. It's unlikely to make her jump out of
yes.
that bed and bounce around. But I think it's
A-
worth taking that shot and seeing whether her fatigue comes
And if
down.
we do not have any CT scan between 2018 and 2026, we do not know when the progression happened.
We don't.
Yeah.
It's just, I know Bhavin is signed off as mild progression over the years, not moderate or significant.
Look, I'm used to the fact that sometimes if you gaze at every single CT section, you will find 3 or 4 sections where one of 6 things that you can look at is a bit worse, and the lung function hasn't changed.
Yeah.
So it does not bother me. I think that by an identical FVC and Bhavin calling it mild, I'm not sure that you've got clinically significant progression on a scan.
Sure. Further, Professor, well, so I'm just wondering actually, I mean, with the aging in a lady, I mean, we see a lot of non-specific autoimmune signals coming through, especially with aging. Do you think, I mean, that could be due to the aging itself leading to this non-specific autoimmune kind of, I mean, autoimmune signals coming through because of the aging itself?
Perhaps I'll
Okay.
make one comment quickly. I think in thinking of this as autoimmunity, the serology is only one out of four things we're putting together. So the fatigue, the serology, and the very slow progression. And there was another one which I've now forgotten. Oh, the ESR. So I think that if you only had the serology, I would be writing this off as something you sometimes see in IPF, which, as you say, may be more likely in somebody who's elderly. But you've got four things that taken together make me believe that probably this is a form of CTD-ILD. Probably.
Yeah. Thank you. Thank you.
Looks like. Yeah, moving on to last case of today's. And for that, we have got Dr. Vishakha Kapadia, who is Associate Professor in SVP Hospital in Ahmedabad. Welcome, Vishakha, and thank you so much for bringing this
Thank you, ma'am.
case. And
Thank you, ma'am.
I'll just share my slides. 1 second. Yeah. Go ahead.
Screen not visible.
This is your case now?
Yes, not visible, ma'am.
Isn't projecting, Asmita.
It's not? 1 second. Now?
Yes, ma'am. Yes,
Yeah.
yes.
Okay.
Good evening, all. Here is a 24-year-old male student from Ahmedabad, Gujarat, no, without any comorbidity. He has complained of dyspnea on exertion, MMRC grade 2 to 3 since 3 to 4 months. No history of exposure to birds or animal or any allergy or seasonal variation. He has nil addiction, non-smoker, and no any significant past major surgical or medical illness. On examination, everything were normal, SpO2 98% on room and no adventitious sound were heard in respiratory system.
You're very
Lab
faintly
parameters.
audible, Vishakha. If you can speak louder.
Yeah, ma'am. Am I audible now, ma'am?
Yeah, better.
Okay, yeah, sure, ma'am. Lab parameters were within normal limits. Hemoglobin, WBC, IG was normal. SGPT create, everything were normal. Even though he was not, hasn't any connective tissue symptoms, still we have gone through RF factor, ANA, CRP, ANA blot, everything were absolutely normal. Her pulmonary function test was done and it was showing severe restriction. FPC was declined to 39%, FE1 39%. FE1 and DLCO, he was not able to perform properly because he couldn't hold the breath. On 6-minute walk test, his distance walked is 432 meter and SpO2 was from 98 to 94%. On 2D echo, ejection fraction was 55% and RVSC was 22 mmHg.
Vimal Raj, sir.
Okay, so this is the CT scan of this 24-year-old patient. In the mediastinum, just interestingly, that they have got an left aortic arch with an aberrant right subclavian artery, which has a retroesophageal course, mild compression of the esophagus, but I don't see that to be significant. The kidneys that we have seen seem to be okay. No major cysts in the kidney, nothing in the liver either, and no significant mediastinal lymph nodes. When we look at the lung parenchyma, what we are seeing from the top itself are these multi-septated, multiple lung cysts that we can see with associated bronchial dilatation. There are some areas of visual nodularity that we can appreciate. Diffuse increase in ground glass change in the lungs. You can see there are these diffuse areas of ground glass opacities and nodular changes which are there throughout the lung parenchyma that we can see more in the lower lobes, while upper lobes seem to be a combination of some cysts with emphysema. So this is fitting more into a cystic lung disease. I would first and foremost think in terms of Langerhans cell histiocytosis as the top of my differential diagnosis that we are dealing with in this case. The other thing of LIP would also come in if he is immunocompromised and if there are other things. The visual nodularity is something non-specific. I think more of the cysts taking predominance here.
Yes, sir. Sir, we did bronchoscopy also in this patient, but bronchoscopy was also not conclusive of any finding. I tried taking a transbronchial lung biopsy, but it was not means it was very hard to take biopsy, so it was also inconclusive. So my question is regarding this because
So
he's
yeah,
24
Vishal,
years.
I think Sharda has joined. If Sharda is there, we can just show the images because
Yes,
it won't open in this computer. I'll open in my other computer. 1 second. So there are 3 images. Yeah, Sharda, if you are there, you can.
Yeah, so this picture is showing only the bronchial epithelium, the bronchial ciliated columnar epithelium with a lot of, I think there is some goblet cell hypoplasia in this. Apart from that, I couldn't find anything else.
Yeah, I'll show the second image. Yeah,
So this is also showing the same, the bronchial epithelium with goblet cell hypoplasia, and there is some on the top right, there is the underlying smooth muscle fibers as well. Apart from that, I couldn't find any alveolated lung parenchyma.
yeah, this is the last one. Yeah,
This is also the same, showing the same. I think few chronic inflammatory cell infiltrate is there.
sure. I think that's it. These 3 slides were there. I could not open it in here. So 1 second, I'll stop sharing. Yeah,
yes, sir. So
questions here.
yes, so means main diagnostic dilemma is there whether to go for cryo lung biopsy for this patient or we can diagnose it as a PLCH. That's why that's what because patient is non-smoker and 24-year old, so and no any exposure history per se. So
Can
Can
this be a BHD, Burton-Hall syndrome?
no,
Because,
it
yeah,
can't be.
non-smoker and PLCH. So PLCH always occurs in a smoker.
Can we go back to the scan, do you think? So the spirometry is appalling, and what I see is an increase in density from the apices to the base. It's uniform. And while I understand raising Langerhans, what strikes me is that as you go through, you've got the sort of things at the apices which, if reproduced throughout the lung parenchyma, might give you severe reduction in lung function. But I think the dominant process throughout the lungs is the increase in density. Now, my concern would be surfactant protein deficiency, that you have a DIP here and you can get emphysematous change. And it's looking more, if you were calling it emphysema, that it's more smoking-related emphysema in a non-smoker, isn't it? So it's really bad up at the apices. And yeah, there are some cysts running here and there, but I don't think the cysts are giving the lung function abnormality. And I don't really understand the ground glass as being part of Langerhans ground glass from the apices to the bases. So look, I accept this is an unusual scan. You could turn out to be right. This could be systemic Langerhans rather than lung Langerhans in somebody of this age. You probably would want to think about that, but my call would be that there's a DIP element which is diffuse. I've seen this a few times in this age group with what is surfactant protein deficiency, and that would be on my list as well. Now, with regard to a biopsy, he couldn't do a gas transfer. You better know the blood gases, hadn't you? Because the DLCO could be down at 15 to 20% here, or 20 to 25. And I think what is interesting, he doesn't saturate much and manages 400 meters. And that tells me that he won't have a vasculopathy. He won't have pulmonary hypertension. But I think somebody otherwise young and fit can do amazing things with ILD that's quite severe, provided there isn't pulmonary hypertension supervening. So this at the moment, we don't have a diagnosis. I think you need blood gases. You need to know the AA gradient if you can't measure the gas transfer before you start making judgments on the safety of biopsy. I think in my book, it's more likely than not you'll get an element of DIP when you biopsy this case, but you might want to do the surfactant protein gene measurements first, because if they're positive, I don't think you need to risk a biopsy.
Okay.
And just because Langerhans been raised, and I don't think you can say this isn't the case, think about checking for symptoms. I think a skeletal survey is sometimes done, but my first step, if you can get it quickly, is the surfactant protein mutation. But I'm now looking for further comments because I don't know what's going on for sure.
You're muted.
We have seen a fair number of BHD now, Asmita, and this doesn't look like BHD.
Yeah, it is not.
So I would keep that out of the differential for sure. And of course, biopsy, I mean, I think he may tolerate a biopsy, a cryo, but his DLCO, we don't have his DLCO, he's not desaturating. Would be interesting to see what a cryo would show, Vishakha. Do you have a high volume center in Ahmedabad?
Yes, actually, sir, we have centers in Ahmedabad for cryo, so we can ask patient for cryo.
But yeah, if, as Athol said, if the surfactant,
Not at our center, actually. Yeah.
if the surfactant
Surfactant protein,
mutation,
that I would, I have to check. Yes, sir. I
yeah.
don't
So
know.
MedGenome would do a surfactant. ICMR
Yeah.
lab in Mumbai does surfactant mutations. If you get those positive,
Yes, sir.
you don't need to do any invasive procedure for sure.
Yes, sir. Yes, sir.
I
I'll check, sir.
Prahlad?
Next, I think I just would like to have, we have seen some young hypersensitivity pneumonia patient developing at very, very young age. Okay. Can this be some sort of an HP case may have developed at a very young age? Okay. And that's why there's a predominantly ground glass which is there in the mid and lower zone of the lung. Cyst formation also can happen in HP. And so that's the thing which I was thinking.
I agree with you. I agree with you, Prahlad, but I've never seen them with this kind of a CT not desaturate. That's my, but it's possible. Yeah.
It also crossed my mind, actually, and I dismissed it in the end, probably wrongly, because of the emphysematous change in the upper zones,
Yeah.
which doesn't really look like the sort of cystic change you see in HP, but it did cross my mind that very diffuse change could be HP. So it's in there still, isn't it? Because whatever this is unusual.
Yeah.
So nobody can say that your suggestion is out of court. Because whatever this is, it will be an unusual manifestation. So if the surfactant serology is negative, surfactant gene is negative, then I think you've got to go back to that sort of question. And I agree on Berthold-Dubé. It really does. The cysts don't look like Berthold-Dubé. You don't get what is driving the lung function. What's driving the lung function is not the cysts. What's driving the lung function is the diffuse ground glass.
Berthold-Dubé patient will not be even symptomatic most of the times, and other than pneumothorax, doesn't happen anything else. I just showed the surfactant protein deficiency patient CT scan in between, and that is very classical of what we are seeing in your case. So I also think that before biopsying, I think worth sending the genetic analysis of patient. Vimalraj sir, there was one radiologist who has asked opinion about one CT scan. If I can share those images.
Sure.
Amyloidosis is another entity which can cause a cystic lung disease.
Yeah, everybody's favorite amyloidosis. I have to say that. Yeah. So, sir, this is the image. The history is very young gentleman from Aurangabad, and he had TB in the past. And his concerns are like why there is a unilateral disease. Because I'm just sharing you. You please tell me to slow down or whatever you want, sir. I'll. So this is the CT and then the mediastinal window. So his doubt is why there is only unilobar. He told honeycombing. I'm doubting whether you can label it as honeycombing, but his doubt is why there is only one lobe involvement. Is it CCAM or is it something? His name is Dr. Apurva. Yeah, he shared this images and his doubts are this. He's working in Government Medical College, Aurangabad.
So I'm definitely seeing there is disease, especially involving the right upper lobe also. The one in the right lower lobe is more obvious. In her, most likely this is an emphysematous lung which has got extensive infection within that lung, which is giving us that appearance, and it hasn't spilled into the other lung that we can, because whenever you have emphysema with any
Yes, sir.
infection, it just looks that bad
Yeah.
within this.
Yeah, I think that's what I also said, that it looks like more like not looking like honeycombing. It is pseudo honeycombing appearance because of the lower lobe and pulling of the secretions, which happens in the lower lobe predominantly and post TB mostly. That's what I felt. Yeah. Thank you. I think that's it. And we had a great discussion.
When you showed the mediastinal windows, was there a bit of calcification mixed in the interstitium? Because that would suggest that it's a residuum, partly, of nasty past infection, wouldn't it? And then maybe there's something else happening on top of that. Yeah. Have you got calcification in there? Yeah.
There is mild calcification,
Yeah.
yes.
Running right through the lower lobe. So you would suspect that's been there for quite some time and is not a more acute presentation.
Yeah, that is what it is. So,
Vishaka, in your case, there was no exposures, no family history, Vishaka?
No, no, sir. No, sir.
Exposures,
No,
nothing.
no exposure.
Any
Yes,
HP
sir.
serology that you have?
HP serology not done, sir.
Not done, yeah.
Yes, sir. Should I ask for it?
I think ask for it, because sometimes if you get a lot of antigens, it's
It
worth
may help. Yeah.
searching harder for a trigger.
Yes, sir. Yes. Sure.
okay. I think that's it. Anybody wants to say something? Otherwise, we will see again on 17th April. That's it.
Thank you.
Thank you. Thank you, everybody.
Thank you.
Thank you, Vimalraj sir, for
Thank you,
taking
sir.
that cases also. Thank you, Vishaka. Bye.
Thank you, ma'am.
I can watch the IPL now.
I have. Are we off call? Are we offline?